Sorry about that, but you're on now.
All right. All right, everybody. Sorry about the technical difficulties, but again, my name is Scott. I'm one of the paramedics with MedFlight. I'm going to talk to you guys this morning about RSI and airway control. As everyone knows, that RSI and airway is something that we do pretty frequently, but it is a dangerous thing for our patients. And we've learned a lot over the years through looking at data, and has shown us that evidence is that we should be spending time to resuscitate our patients and get them ready for the intubation itself, setting ourselves up for first pass success. And we're going to talk about some ways that we can do that. Hopefully everybody knows what is, or at least has heard of, what's called -1A.
I have not.
-1A stands for definitive airway sans hypoxia. They also include hypotension in that on first attempt. That's what -1A stands for. It's kind of a metric that a lot of people are using. And the reason for it is evidence has shown that just simply having to make a second attempt to do an intubation increases the patient's chance of having an adverse outcome exponentially. I want to say it's like 60-something%, but don't quote me on those numbers. It's a high number.
Totally quote you, Scott said.
Yeah, so that's why it's so important that we get our patients successfully intubated on the first attempt. And we have found through research and looking at statistics and data and this and that and the other, there's a lot of factors that go into that. Things like setting the patient up a little bit, positioning them depending on the patient. Using a checklist, making sure that we have everything ready to go that we're going to need, suction, things like that, even medication choice. So we're going to go over quite a bit of that in this lecture and talk about how we can set ourselves up for success. So some disclosures before we start. Basically, this is just letting you know that while this is evidence-based information, it's not really, a certifying thing where we're, telling you can go out and do these different things. Make sure you follow your local protocols or guidelines. However, we do encourage you to, if you see something in your protocols or guidelines that need to be changed, or you feel like need to be changed, get with your medical directors and try to make those changes. This is a CE activity. At the end, there will be a QR code that you can scan and get CAPC CE for it. This is not my PowerPoint. This was made by Air Methods, and I don't have any financial ties to it. I'm not making any money off of it, unfortunately. So again, this is not going to certify you to perform RSI. Make sure you're following your local laws and regulations. Objectives. We're going to talk about when RSI is needed. Sometimes if we can avoid RSI, that might be the best thing for the patient. Just depends on the situation. We'll talk about some different steps, calculating some drugs, and we're going to talk a lot about resuscitation strategy prior to RSI. As always, we always start these off with an anatomy review, and I like this picture on this slide just because it shows you mainly how large the tongue is in relation to the other structures in the airway, which is going to be one of our biggest obstacles to getting patients intubated, right? The epiglottis. We're going to talk about vocal cords and how to make sure that you're in the right place. I don't have any pictures other than this, but there are several out there if you want to get online and do some searching when you're not busy. There are some pretty interesting pictures of airways out there that on first look looks like vocal cords and looks like an airway, and it's actually not. It's the esophagus. So if you are somebody who is responsible for intubating patients, you need to make sure that you know this anatomy and that you can recognize the arytenoid cartilages, things like that, so that you know for sure you're in the right spot. This is a fairly good view of an airway. You can see the epiglottis really good there at the top. The arytenoid cartilages is that kind of V-shaped structure that's below the vocal cords there. And of course the vocal cords themselves. Now I will tell you that airways don't always look this good, particularly on burn patients. You may not be able to even identify vocal cords. So that's why it's so important that you can recognize these other structures. There's things that you can't really see in this picture, but you can also look for the tracheal rings, etc., to make sure that you're actually putting the tube in the trachea. All right, so what are some indications for RSI? Well, obviously, ventilation and oxygenation of the patient, and then keeping a patent airway. A lot of this is going to be patient dependent, right? So are they ventilating well? Are they oxygenating well? Do they have an airway at all? It's going to kind of, depict what path we go down and kind of what kind of time we're going to have. They may have a patent airway now, but we're anticipating that in a few minutes they may not. So those are some things to keep in mind. We're getting into equipment. As far as your laryngoscope blades go, most of you are probably aware of the Macintosh or curved blade. The way the Mac is designed to work is the tip of the blade slides into the vallecula just above the epiglottis. There is a ligament back there. I can't remember the name of it, but that actually, when you lift up that structure, it lifts the epiglottis up. There is a fair amount of strength required to do this, depending on the patient. And as you know, you're going to be holding that in your left hand, and most of us are right-handed, so it's going to be your non-dominant arm. But we're going to talk about some ways to augment that. The Miller or straight blade actually physically lifts the epiglottis itself. It is preferred in pediatrics, mainly because it just doesn't take up as much room in their airway like the Mac blade does. The Mac blade is good for tongue control, sweeping the tongue off to the left, more so than the Miller. And some of it, quite honestly, is just personal preference. Some people really like the Mac, some people really like the Miller. But I would encourage you to practice with both of them, because you never know when one of them is not going to work, or this might be all you have for whatever reason. Personally, I like the Mac blade. And a lot of that's just because I've been very successful with it. A lot of times I use a Mac like a Miller. And we'll talk about that a little bit. Video laryngoscopes are getting to be more and more popular as time goes on. It's almost becoming a standard of care to have these. They are rather expensive, unfortunately, but they do provide you a very distinct advantage, particularly for difficult airways. They have been shown to increase overall first pass success quite a bit. Again, great for difficult airways. There are some nuances to using video laryngoscopes, and one of those is keeping your camera lens clear. That can be difficult depending on the patient. One of the ways that you can do that is to lead with suction. And this is a kind of a hard habit to break, but you really should be holding your laryngoscope in your left hand and suction in your right hand when you start, versus holding the ET tube. And the reason for that, the reason for leading with suction, is to keep that camera lens clear. We're going to talk more about that as we move through this. The CMAC, particularly, that you're seeing in the picture there, one of the advantages of that particular laryngoscope is that it can be used, it's shaped like and can be used exactly like a regular manual laryngoscope. You can do direct laryngoscopy with it just like you would with a regular laryngoscope. In fact, that's usually what I do. And the reason I do that is I'm trying to keep that skill of direct laryngoscopy. What they're finding with a lot of these video laryngoscopes is that people are becoming dependent on them to the point where they can't do intubation without one. And that's not where we want to be, right? You never know when that camera, electronics get messed up, something doesn't work. You need to be able to go back to the old way of direct laryngoscopy. So don't lose that skill. The bougie, most people have these now. These are particularly important with difficult airways. They're a little bit easier to pass. They can be used as a tube exchanger as well. They do come in different sizes, adult, ped, and they even have some out for infants now. However, the infant size it's so flexible that you can't really use it as an introducer, but it does work great for exchanging tubes. The big thing to know is that you cannot use a stylet as an alternative for a bougie. They're not one and the same. This has been done, and you can cause a significant amount of airway damage and trauma from using a stylet as a bougie, so don't do that. So the endotracheal tube itself obviously comes in different sizes based on the patient's height. There's cuffed and uncuffed. Hopefully everybody has transitioned back to cuffed only tubes, even on your little baby ones. One of the things that we used to do in the past was cutting tubes down. The reason that we did that was we thought it helped prevent airways getting pulled out or kinked, or whatever the case may be. The problem with that is our patients get handed off to so many different people, and if that information doesn't get passed along, they're going to look at that tube and think, oh my God, that's way too deep, and then they end up pulling it out. So it's a good habit to just not cut tubes. We don't do that anymore. use an elbow or something like that if you're having problems with it kinking off. There's other things that you can do. ET tubes are designed to be inserted with the cuff just past the vocal cords. And you want it to be above the level of the carina to where you're ventilating both lungs equally. If you get it too deep, it's almost always going to go right main stem. So if you've got lung sounds on the right after you get your patient intubated and not on the left, more than likely it's in the right main stem. So don't panic. Just deflate your cuff and back it up 1 to 2 centimeters, reinflate, and listen again. Sometimes you have to do that a couple times. One of the things that we have found is that, you know, when we were in medic school, whatever, we were taught, you know, don't let go of that tube. And most of us are pretty good about never letting go of that tube until it's secured. The problem is, the other thing that we have done is that we're pushing down on it just to make sure that it doesn't come out without even realizing it. And a lot of times we end up pushing the tube way down farther than it needs to be. So the key to all of this is to reassess your patient. Be constantly reassessing the patient. And don't be afraid to make corrections. Some pre-medications for RSI. Fentanyl. Some folks are still doing this. Atropine, specifically for your little kiddos. This is particularly important for kids that are less than 1 year old, that are not markedly tachycardic. And what that means is, you know, if they're not above about 160, you probably should think about giving them some atropine as a pre-medication to keep them from getting bradycardic. I would tell you, at the very minimum, to have it out and ready to go if you don't give it as a pre-med. Induction, again, follow your local protocols on this. Ketamine's probably one of the more popular sedatives out right now. Etomidate, still use that. It's kind of gotten a bad name over the years. We used to call it Vomidate because the patients almost always vomited when we gave it to them. We found out why. It's because we were pushing it too fast usually. And then, of course, Versed. We have actually taken Versed out of our RSI protocol simply because it has been linked, again, through evidence and research. It's almost all patients that had some kind of an adverse outcome were given Versed as an induction agent. That's not to say that you can't still use it. If it's in your protocols, make sure that you're following that. It does work well. The problem with it is it drops their blood pressure, right? And a lot of times that's counterproductive to what we're trying to do. So just think about that. As far as your paralytics go, we're going to talk about some different ones. There's depolarizing and non-depolarizing. This kind of talk about how those different ones work. Rock and sucks are probably the two most popular ones that are used in EMS. Vecuronium is still out there. We have it as a backup just in case rock's not available. Succinylcholine is still used quite a bit, but Sux has so many adverse effects and contraindications that we've kind of gone away from it. But it is out there. A lot of people like it because it has a short half-life, which can be beneficial in some patient populations. The Heaven criteria is a difficult airway prediction tool. This is something that was born at Air Methods. It's basically a combination of lemon and a few other tools that were already out there. But basically what it is just a mnemonic to remind you of some things to look for. You know, is my patient hypoxic? You know, that means I'm not going to have as much time. Are they extremes of size? And this is both large and small. Do they have some kind of an anatomic disruption or obstruction? V is for vomit, blood, or fluids in the airway. Again, we're going to talk about suction quite a bit. Exsanguination, obviously that's a big deal. We want to stop that and resuscitate if necessary with fluids and blood if you have it. And then neck mobility. We're going to talk about C-collars and opening those up if they have a C-collar on, and some ways that we can mitigate each one of these criteria. Again, it's just to get you thinking about, okay, I need to have this ready, you know, having a backup plan, having that equipment out and ready to go, and also making sure that everybody's on the same page. If, you know, RSI is not a individual sport, it's a team sport. So make sure that you're talking with your team and that everybody's on the same page and knows what's going to happen, depending on what you find. The Mallampati score, everybody's probably seen this before. It's scored 1 through 4. Obviously, the higher score, the more difficult the airway is going to be. The problem with this is the patient has to be awake and alert to do this. This is where you're getting ready to go in surgery and they ask you, hey, stick out your tongue. This is what they're looking for. So very few people are class 1. I know a lot of times we put in our charting that they're Mallampati class 1, but it's probably more likely to be a 2. And then of course 3 and 4 are the ones that we don't really want to see, but it should kind of pique your suspicion that you're going to have a more difficult time getting that airway. This is the lemon that I mentioned earlier. A lemon stands for look externally. So you're looking for trauma, any kind of things on the outside that are going to cause you problems. Beards and mustaches is probably a big one. A lot of guys with big beards these days. That's kind of come back in style, but it causes us a lot of problems when we're going to try to ventilate our patient, pre-oxygenate them to get ready for RSI. And then looking for a large or swollen tongue. The 3-3-2 rule talks about, if you can fit 3 fingers between their incisors, 3 between the hyoid bone and the base of their jaw, and then 2 between the thyroid and the mouth. So this is just basically evaluating how wide their mouth will open up, and then approximate location of the airway, whether they're going to be anterior, superior, etc. The Mallampati is what we just looked at. We want that to be a 3 or better. Obstructions, anything that you may have to remove with your McGills and or work around if it's some kind of an impaled object. And then neck mobility, again, is, that's always been a big thing that we deal with on our larger patients particularly. Pediatric airways. obviously high risk, low frequency. This is something that none of us ever really get enough practice to be proficient at these. But so it's even more important to talk with your team, talk with your partners about things to anticipate and how you're going to mitigate some of those. Some things to think about, obviously, their tongue is larger in proportion to the other structures of the airway. They have what's called known as a floppy epiglottis. It's just not as developed as it is in an adult. It's not as firm. So you may not be able to get that epiglottis lifted up. That's why the Miller blade is preferred in pediatrics. Their airway is usually more anterior, and it's more of a cone shape. So it's important to have various size tubes ready to go. They may take a smaller tube than what you're anticipating, so make sure you've got those out and ready to go. Difficult airways, and we'll talk about this more in the next section, but any kind of trauma, especially if it involves the airway itself, burns, anaphylaxis, OB patients, anything that's going to cause angioedema of any kind. And we'll talk about some of those. Talked earlier about one of the things that we've done to try to set ourselves up for first pass success is the use of a checklist. And this is something that came from the aviation industry. Our pilots, they use checklists for everything. They use a checklist to start the aircraft. They use a checklist to shut it down. They use a checklist for emergency procedures. Nearly everything they do has a checklist that they use to make sure that they don't miss anything. And somebody somewhere along the way said, hey, why don't we do that? It makes total sense that we have a checklist that to make sure that, hey, you've got your suction ready to go, you've got all this stuff hooked up. Because in the past, and if you reflect back on your career like I have, there were times that, you literally just grabbed the laryngoscope and a tube and intubated them. And a lot of times we were successful doing that. But we've also had that oh crap moment where something didn't go right and you don't have anything ready, but now your patient's paralyzed and sedated and you're kind of behind the 8 ball. There's a few different versions of this out, but this is something that we encourage people to use. We have these that we hand out to folks, so if anyone's interested, just let me know. But again, some of this may sound like common sense, but you'd be surprised when you're, in the moment and your adrenaline's pumping. It's easy to forget some of these things. So make sure that you've got the patient on the monitor. Make sure that they're not bleeding out everywhere, right? If they have some kind of a external hemorrhage, we need to stop that, and we need to resuscitate them with fluids and blood if they have it. If they have a tension pneumo, we need to decompress that. Make sure that we're pre-oxygenating them, whether that be with a non-rebreather mask, nasal cannula, BVM, whatever, depending on the patient. Putting passive oxygenation in place. That's where we put a nasal cannula in their nose and crank it up to about 10 to 15 liters. This will both pre and passive oxygenate your patient. You may have heard it called apneic oxygenation, which is kind of an oxymoron, but the thought process there is that even after you sedate and paralyze the patient, that oxygen is still going to be going, forcing through that cannula down into the airway, and it has been shown that does make it down into the lungs and will help keep your patient oxygenated, all of which buys you time to get that airway in place successfully on the first attempt. Don't forget about your OPAs and NPAs. This is something that for years we hardly ever even used those. It seemed like we went from straight from, you know, a non-rebreather to intubating them, and we would just use the BVM. But we're going to talk about using an OPA and NPA, especially when we're taking those important few minutes to get the patient pre-oxygenated. It's going to help you during that process. I mentioned elevating the head of the patient, and we're not talking, you know, major. It can be, you know, this says 30 to 35 degrees, even 15 degrees, depending on the situation, can be very beneficial. Make sure that they're oxygenated, you know, especially if they started out hypoxic. We want to take the time to get them re-oxygenated and back up. Our target is 93%, and you'll see this some more later in the difficult airway lecture, but about why. But some places are different. Some people say 92, some say 94. Somewhere in that range, you want them to be above low to mid 90s preferably. And we'll talk about taking the time to do that. One of the ways that you can do it is what's called the 2 thumbs up technique with a BVM. This does take 2 people to do, but it works. You use 2 hands to hold a mask seal over the patient. It allows you have a lot more strength with your hands that way. The heel of your hands are on the mask, and your fingers are pulling their jaw up into the mask. You can hold their airway open at the same time. Obviously, somebody else has to squeeze the bag. It works particularly well if you have a PEEP valve on your BVM, which a lot of them come that way now. And we also go ahead and hook up end-tidal to it as well. If they have a C-collar on, don't be afraid to open that up. Again, you know, reflecting back on my career, I can think of some times where probably should have done this. Point being is, don't let a C-collar prevent you from being able to get your patient intubated. Go ahead and open that thing up. You can still hold manual C-spine or have someone else do it for you. But we want to get that airway on the first attempt, and one of the ways to help you do that is to get that C-collar opened up. And then look for your Heaven criteria. Get your equipment set up. Make sure you've got suction on. It's hooked up and accessible to you. I would tell you to go ahead and turn it on. We're going to talk about leading with suction. If you have a video laryngoscope of some type, make sure that that thing is connected, turned on, and ready to go. This mentions warmed up. There are a few of them out there that take a little bit to get warmed up, so go ahead and get those turned on. Make sure you have your induction and paralytics decided upon, drawn up, doses confirmed with your partner, and then of course your airway equipment, your ET tube. Make sure you've got check the cuff, you got a bougie, and then your backups, whether that be a King or a whatever kind of backup airway that you're carrying. Make sure that you have that out and ready to go in the right sizes. And then moving into the procedure itself, you're going to give the induction agent, give it time to work, then give your paralytic, give it time to work. Make sure that everything's ready to go. Suction prior to the intubation attempt. And this, you know, whether you're using video laryngoscope or not, I would tell you to make sure that you suction the airway out. Get the patient intubated, and then we're going to talk about confirming placement. Obviously, seeing the tube go through the cords is ultimately what we want. We're going to listen to breath sounds, starting with the epigastric. You should not hear anything there. You should have breath sounds on both sides. And then ultimately what you're looking for is return of end-tidal CO2. to make sure that you have that good waveform capnography. And this just kind of shows a close-up of each one of them. As far as resuscitation goes, we're looking for a MAP greater than 65, systolic greater than 90. Make sure you're looking at your shock index. Again, the way we're going to treat this is with fluids, blood if you have it, and then push dose pressors if you have that in your guidelines. Phenylephrine and epi are probably the two most popular push dose pressors that folks are using, and there's some dose ranges there. We use phenylephrine quite a bit, and our protocol is that we can give that, used to be 15 minutes before and up to 15 minutes after the intubation. Now there's really no time limit on it. It's kind of basically buying you time to get a pressor mixed up and a drip ready to go. Again, oxygenation, the way that we're going to affect that is not just by 100% FiO2, but with PEEP as well. Make sure that if you have PEEP valves, use those. They do work. Don't forget your simple airway adjuncts, your OPAs, your NPAs. Set them up and get that passive in place. Your BVMs, obviously make sure you have the appropriate size. And this kind of shows the 2 thumbs up technique with a BVM. And I understand that this can be a challenge on the ground when there's only 2 of you, but it does work. If you have somebody that you're not able to get reoxygenated, give that a try. It almost always works. Adults, make sure that you set them up. You want their ears to be level with the sternum. And you can do that various ways, either just sitting them up or putting some towels, a pillow, whatever behind their head. And this goes for large adults, pediatrics, anybody, you may have to pat under their shoulders to get everything lined up. But the goal is to get your axis view lined up. And the best way to do that is to bring the patient to you, instead of squatting down, bending over, holding your head sideways like we used to do with everybody laying flat. This shows using a angled pillow. But again, you want to get their ears level with the sternum. And what that's going to do is get your airway lined up where you can see it. Direct versus video laryngoscopy, there is a little bit different approach. Direct, the way I always used to do it is basically bury the blade and then back it up till I saw the epiglottis fall down into view. Then I knew I was in the right place, slide it up into the vallecula and lift up, and that almost always worked for me. Problem is with a video laryngoscope, if you do that, you're almost always going to contaminate your camera lens. So it's more of an out to in approach. Again, to make sure that you don't mess up your camera lens. Again, position them, remove any obstructions. That includes C-collars, lead with suction. And what I mean by that is have that suction catheter out in front of your laryngoscope blade to make sure that you're not going to bury that into some vomit or blood or whatever's in there. Look for your landmarks and make sure that you're lifting away from their face. You don't want to be wrenching back on them. So when do we stop an RSI? Well, attempts over 30 seconds, and again, this is patient dependent. So you remember back in school when they would tell you you had to have your partner give you an out loud count of 15. This was the reason behind that, because typically that got you to where you were about at a 30-second attempt. And if you weren't successful by then, you probably needed to back out, bag them up, as they called it. But preferably we want to pre-oxygenate them and resuscitate them to where there's times where, I mean, it can be a minute, minute and a half, even two minutes before they start desaturating, if you have taken the time to pre-oxygenate them well. Obviously, if they start getting hypoxic, we want to stop and correct that. You don't want to let them fall off that cliff on the carboxyhemoglobin curve. If they start getting hemodynamic instability, again, we need to resuscitate them. If you can't visualize the landmarks, or if you have made 3 attempts. And don't forget, you know, I've talked a lot about first pass success, but if you don't get it on the first attempt, don't panic. Just make the corrections, and on your second attempt, make some kind of a change, whether that be a different size tube or a different blade, or reposition the patient. Change something. You know, don't continue to try the same thing that's not working over and over and over again. That's the definition of insanity, right? Make sure you've got your alternate airways available. Backup airways, rescue airways, whatever you want to call it. But after you've made 3 attempts, you probably need to be moving to your alternate. Just get something in there that's going to work to keep them ventilated. Ultimately, we have to ventilate, right? We don't have to intubate, but we do have to ventilate the patient. We've already talked about confirming the tube. Obviously, you want to visualize it passing through the vocal cords. And this is another nice thing about the video laryngoscopes, is that everybody around you can see that screen. I talked earlier about how I like to still do direct laryngoscopy. Typically what I'll do is I'll tilt that screen back where it's straight up and down. That way everybody around can see what I'm seeing looking through there. And I can still see it myself. If I need it, I just literally look up at it. But everybody else can see that tube go through the cords and knows that it's in the right place. But don't forget to listen to your lung sounds. Look for chest rise and fall, all those kind of things. And then obviously your waveform capnography. Cuff tube pressures is a big deal, especially if you're going to have a long transport. Probably not quite as crucial for you guys, but it has been shown to cause damage to the tissues of the trachea by putting a full 10 mLs of air in those cuffs a lot of times, depending on the patient again. So that's why we carry the cuff manometers. We usually try to keep that around 20 to 25. We don't fly high enough around here for it to really affect things, but we do still check it in flight, make sure that it's at the appropriate pressure. And then, of course, your post-intubation sedation. This is important. We want to make sure that we keep patients sedated, treat them for pain, those kind of things. And again, these are just dose ranges, so make sure you follow your protocol on that. Let's just kind of talking about when to call a helicopter and some of the assistance that we can provide for you guys. In summary, RSI does require quite a bit of preparation and time to set the patient up for and yourself up for success. Make sure that you pre-oxygenate them. That's probably the most important thing. That and resuscitating them to where their blood pressure has a MAP greater than 65. And what we're doing with this is we're trying to keep them out of that peri-arrest condition where we have in the past intubated patients and then within a few minutes they code on us, right? So that's what we're trying to avoid. Make sure you've got your backups ready and that everybody around you knows what that backup plan is. That's it on that one. There's the QR code for the CE hours. Anyone have any questions on any of that?
20-ish seconds behind.
Yeah, it just goes into. You have a question?
Mm-mm, not yet. But that just lags.
Oh, it's lagging a little bit.
Yeah, it's like 20 to 30 seconds. So,
Okay.
do you want like a 5 minute
Yeah.
or so?
Yeah.
We're gonna stop and restart, aren't we?
Yeah, we can.
Please. All right. If you have any questions, ask me much of anything.